Hey, and welcome to our Healthcare Solutions webinar, COVID-19 Government and Industry Updates. My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for Attentive. Before we dive into today's webinar, I want to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded, and we're going to send out a copy of the slides and the recording. We usually go within the next week. I've been trying to get these out within the next day or two because I know that this is crucial stuff for your practice right now. So I will try to get this out to you as soon as I can, hopefully within the next day. Next, for those of you who aren't familiar with Attentive, you'll notice that this is a bit of a different format for webinars than we traditionally offer. We're offering these brief mini webinars on topics that pertain to COVID-19 in hopes that your practice will find them helpful in manning and getting through the current crisis and assisting your practice with that. So in the same theory, I wanted to mention some upcoming webinars that we're going to have continuing in the COVID-19 mini-series. On Wednesday, we'll be covering protecting your practice from hackers amidst the crisis. And on Friday, we'll be discussing utilizing NextGen mobile during the COVID-19 crisis. And on Monday, April 6th, we will be discussing keeping your patients informed during the COVID-19 crisis with NextGen messaging solutions. So all of those you can sign up for right now on our website on the Events and Education page. The registration links were all in the same email, in the email that you used to sign up for this webinar. If you can't find them or if you want help registering, just shoot any of us an email and we're happy to help you and get you registered for them. Okay, so back to today's webinar on government and industry updates as they relate to the COVID-19 crisis. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. Without further delay, I'd like to introduce the presenters for today. Lindsay Lanning is Manager of Client Development, and Carly Hogan is Client Solutions Administrator at Attentive. So Lindsay, the webinar is all yours. Take it away when you're ready.
Great. Well, thank you, Chelsea. And hi, everyone. Thank you for jumping on today to learn more about COVID-19 and government industry updates as part of our mini educational webinar series focused on topics surrounding the current COVID-19 crisis. So on today's agenda, we're going to review the temporary HIPAA changes and updates and those rollbacks associated with that. Some telehealth reimbursement changes as they pertain to Medicare, Medicaid, and some kind of guidance here on private payers as well. A really important DEA change involving ePrescribing controlled substances, the elective surgeries and non-essential procedure recommendations that were released, as well as the Quality Payment Program or MIPS deadline pushback. And you will notice our disclaimer at the bottom of the slide. This is disclaimer one of, I would say, many throughout the presentation. Basically, it states that we're not here to advise you on what to do, just provide the resources and knowledge that are crucial to be aware of for your practice operations during this very unique and very challenging time. So we're really focused on providing what is fact, and this is where you find it, to allow you to make your own decisions in your practice and what's right for your practice during this time. So to start and kind of jump right in here at a very high level and identify where all the changes we're going to go over in the webinar today came from, they're actually from these three pieces of key legislation surrounding COVID-19. So Congress has actually completed 3 rounds of legislation in response to this pandemic and resulting economic crisis. It includes an $8.3 billion supplemental appropriation. That's that top one here. We'll call that round 1. That was signed into law on March 6th, which provided emergency funding and included all of those Medicare telehealth waivers that we'll go over today. Round 2 was the Families First Coronavirus Response Act, which President Donald Trump signed into law on March 18th. This addressed really the domestic outbreak. It included things like paid sick leave, as well as nutrition assistance and unemployment benefits. But our focus today will actually be broadening the insurance coverage of corona testing in this specific round. Round 3 was actually signed into law on Friday. It's called the CARES Act for short. And it really extends Medicare telehealth to FQHCs and RHCS. It actually grants $29 million per year for the next 5 years to various telehealth networks and resource centers. And it requires full insurance coverage of immunizations and preventative services for COVID-19 without any cost sharing. And those are just 3 things among the many other things related to the stimulus package portion of it. So again, just trying to start with big picture where these changes impacting your practice are coming from. So let's get started with the temporary HIPAA changes and updates. And notice my not so subtle emphasis on temporary. Long story short, CMS released a major announcement on March 17th regarding telehealth regulations and their changes during the COVID-19 public health emergency. So in order for clinicians to provide necessary telehealth services, the Office of Civil Rights, or OCR, began waiving penalties for HIPAA violations against any healthcare providers who are serving patients in good faith through everyday communication technologies. This means that, if necessary, providers can actually furnish telehealth services to their patients via communication technologies such as Apple FaceTime, Google Hangouts, Skype, Zoom, etc. So this applies to telehealth that is provided for any reason related to COVID-19 or not. Basically, OCR will not impose penalties against covered healthcare providers for the lack of a business associate agreement with those video communication vendors, or any other non-compliance with the HIPAA rules, as long as it relates to the good faith provision of telehealth services during that COVID-19 public health emergency. Now, we understand there are many solutions out there offering temporary assistance. We at iTenev are actually advising our clients to use NextGen virtual visits powered by AutoHealth, since they've actually offered a non-integrated solution that can be implemented and launched in a much more condensed timeline than before. However, if you are a specialty that, telehealth may never be useful in the future, except in the time of an extreme circumstance like this, we have recommended Zoom. We have gotten a lot of client feedback and concerns when quoting the above announcement that you're seeing, lately saying that these solutions are not HIPAA compliant, and we do know that. This legislation is only in effect for the remainder of the public health emergency. It is temporary, and it is what is allowing practices to use these otherwise prohibited solutions to conduct telehealth visits. Now, I did include a screenshot of the announcement as well as a link to it, so you can read the press release in its entirety when we do send out the slides. Now, with that being said, again, we do urge clients who could offer telehealth services in the future, even after COVID-19, to consider a more permanent solution such as Auto. One of our clients said this to us, and I wanted to mention it. Telehealth is going to be like toothpaste. They made this awesome analogy that once it's out of the tube and being used, you just can't put it back in. Patients are going to experience this new type of visit, and they won't stop wanting it overnight once we get beyond this crisis. So we want to keep that in mind. But I will get off my mini soapbox and get back to what this rollback exactly means, because this is not a blanket approval of insecure technologies. When we look at this notification and the HIPAA security rule, there are still several important pieces of guidance to follow. So while HHS still encourages providers to use solutions that are HIPAA compliant if possible, and obtain a business associate agreement if possible for the duration of this national emergency, they're not going to penalize providers for the use of products that will not enter into these agreements. However, providers should notify patients that these third-party applications potentially introduce privacy risks if you're using them. This is a standard disclaimer that should be part of the communications or consents you're using during these patient visits if you're using these products. OCR's expectation is that providers should enable all available encryption and privacy modes when using these applications. So that means if applications that provide a reasonable and appropriate degree of security and transportation, so think FaceTime, Zoom, Google Hangouts, Duo, Microsoft Teams, WebEx, those products actually offer a degree of security within them, and those should be used. No public or broadcast apps. Applications that facilitate public-facing communications, think like Instagram Live or Facebook Live. A new one I've seen that I don't truly understand is TikTok, or similar ones that allow you to broadcast to the internet should not be used. And then, of course, document the technologies used. You should still document in the encounter notes of your electronic medical record the date, the time, and the method of communication used, as these systems may not log or audit this information the way a more compliant product would. So truly, this is excellent guidance from the OCR that really speeds up the availability of critically needed technologies to the hands of the providers by providing this temporary respite from, the vendor risk analysis or the contracting component that's usually involved. However, it does not absolve providers of their responsibilities under state laws, and it still requires them to take reasonable and appropriate steps to protect patient safety and patient privacy and inform patients of the potential risks. And it should be noted that many states actually do have laws and regulations regarding health information and what's required to protect it and secure it. So those will likely not impact. Those state laws are still in place and should be looked at. We would recommend looking into your own state if any of these changes have occurred as well. Now, the Office of Civil Rights has also issued guidance regarding the disclosure of PHI about individuals exposed to COVID-19. I know that there have been a lot of questions on what can be shared and what can't be. So the short answer, taken directly from the OCR guidance, is that yes, the HIPAA privacy rule does permit a covered entity to disclose the PHI of an individual who's been infected with or exposed to COVID-19 with law enforcement, paramedics, first responders, and public health authorities without the individual's HIPAA authorization in very certain circumstances. So I won't go over the specific instances where it's allowed or not allowed. I've provided the link to the guidance so you can review it yourself if this applies to you or your practice. Overall, after reading the guidance, it just really makes sense. It's truly focused on sharing PHI for the sake of public health and containing the spread of the virus. But again, I encourage you to review it if you have questions, and we provided that link here. So we're going to go ahead and actually dig into the new telehealth regulation changes that were put into place by CMS, again, only during this public health emergency. We'll start with the changes for Medicare, and we'll also discuss Medicaid and private payers. Keep in mind, we can provide much more detail on Medicare because traditional fee-for-service Medicare is uniform nationwide. Everyone else can basically set their own rules, and we can't possibly know every payer in the country and know what's required and what to look for. Medicaid is state-specific, and private payers are truly each unique, and let me tell you, they are all over the place with their requirements. So I will actually turn it over to Carly to take you through the interim changes.
Awesome, thank you, Lindsay. So as she mentioned, we'll start by discussing the new Medicare fee-for-service telehealth guidelines. So beginning with services rendered on March 6, 2020, certain Medicare telehealth payment requirements were waived during this public health emergency to allow beneficiaries in all areas of the country to receive telehealth services, including at their home. Many services that traditionally could only be furnished in person can now be furnished via telehealth, and an established relationship between the patient and the provider does not need to be in place in order to bill. So prior to this declaration of the public health emergency, telehealth was only reimbursed by Medicare on quite a limited basis. Very few services were reimbursed. Patients usually had to be in a specific location to receive the services, such as a rural area or in a specific facility at the time the service was provided, and an established patient-provider relationship had to be in place. So now that all this has changed, at least temporarily, we're going to go over the new requirements for telehealth reimbursement. So first, Medicare issued a licensing update, meaning that healthcare professionals do not necessarily need to hold a license in the state in which they're providing a service, as long as they have an equivalent license from another state. And CMS has still not issued specific guidance on how this is being implemented, so we are still on the lookout for that. And in order to provide a telehealth service, the provider must still use an interactive audio and video telecommunication system. So nothing's really changed there either. As a reminder, as Lindsay said, those HIPAA rollbacks are allowing temporarily to use systems like FaceTime or Skype during the public health emergency. And if the provider is providing services over a phone only without video, the telehealth codes cannot be billed for those services, at least for Medicare. So it must still be that audio and video combined. As mentioned earlier, all geographic restrictions have been waived. Patients can receive telehealth services from anywhere, including their home. And as far as the provider-patient relationship update, the CARES Act, which was passed on Friday, officially waived the established relationship requirement, meaning a provider had to have treated a patient within the past 3 years in order to bill for telehealth services. So just to clarify, prior to the passing of CARES on Friday, although the established relationship was not officially waived, HHS had announced that they were not conducting audits to track whether a prior relationship was in place during the public health emergency. Next, the types of providers who can bill for Medicare for telehealth services has not changed either. So we still have physicians, nurse practitioners, PAs, nurse midwives, CNSs, CRNAs, clinical psychologists, clinical social workers, registered dietitians, and nutritional professionals. All of them can bill for telehealth services, and this was the same before and during the COVID crisis. And now moving into out-of-pocket costs and copays. So these do still apply, but healthcare providers and practices now have flexibility to reduce or even waive these fees at their own discretion. And one question that has come up a lot is, will you still receive that 20% of your payment if you waive the copay? Unfortunately, the answer to that is no. CMS is still only providing you with that 80%. So that's really why the copay is at each practice's discretion. And of course, the biggest change related to telehealth during this public health emergency is that providers can now use standard E&M codes to bill for telehealth services. These codes have always been typically used only for in-person services, but now the place of service code of 02 can be added to indicate that it was furnished via telehealth. And again, these telehealth services furnished by practitioners during this time can either relate to COVID or be completely unrelated. And telehealth visits will be paid at the same rate as in-person visits. I also want to note that under the Families First Act, Medicare is required to fully cover the cost with no deductible for patients of coronavirus testing related services, which includes a medical visit that results in an order for or administration of a coronavirus diagnostic or screening test. The medical visit could occur in person or via telehealth. And we've received a lot of questions on advice for documenting these telehealth services within NextGen and best practices regarding that. So luckily, NextGen did recently release a document on the Success community going over the recommended workflow in the EHR for virtual visits, and it has some really helpful information. So we are going to be sending that out with the follow-up email and slides, which can hopefully answer more of your specific questions that I'm sure are going to start coming in. And then the last topic we want to hit, specific to Medicare telehealth reimbursement, is regarding FQHCs and RHCS. So since we serve a lot of FQHC clients, we wanted to make sure we include this information. So as of the passing of the CARES Act on Friday, FQHCs and RHCs are officially authorized to serve as distance sites, meaning their providers can furnish telehealth services to beneficiaries in their home or other settings. Medicare will reimburse for these services at a composite rate similar to payments provided for comparable telehealth services under the Medicare physician fee schedule. Also, the cost associated with these services is excluded from both the FQHC prospective payment system and the RHC all-inclusive rate calculation. And I do want to clarify that telehealth and virtual check-ins are not the same thing. So FQHCs and RHCs have been able to perform and get paid for virtual check-ins since before COVID and the public health emergency ever happened. And although both telehealth and virtual communication services use technology to communicate, these are separate and distinct services. So telehealth services use both audio and video and really are considered a substitute for an in-person visit, which is why they're paid at the same rate. Virtual check-ins are not a substitute for a visit. Instead, they're more like a brief discussion with the practitioner to determine if an in-person visit is necessary, which is why, as you can see, they're paid at a much lower rate, typically more like $14. So that pretty much sums up the new Medicare fee-for-service guidelines. And of course, when Medicare makes a change, we know Medicaid and private payers are pretty quick to follow suit and put out their own guidance surrounding that topic, and this situation was no different. So taking a look at Medicaid here, the passing of the Families First Act on March 18th required Medicaid to begin covering all testing for COVID-19 using funds provided by the federal government. CMS and members of Congress have strongly been encouraging states to cover Medicaid telehealth services, and no federal approval is needed for state Medicaid programs to reimburse providers for telehealth services in the same manner or at the same rate that states pay for face-to-face services. However, a state plan amendment would be necessary to accommodate any revisions to payment methodologies just to account for those telehealth costs. So because of this, many states have now started to utilize telehealth for Medicaid patients. And in order to cut even more red tape and temporarily remove some requirements that can often hinder access to Medicaid care, more and more states are applying for what's called 1135 waivers. As of Friday, we have had 34 states approved for this waiver, and we'll probably still continue to see this number grow. These waivers cover a variety of provisions, and some of them include the ability to bypass some prior authorization requirements, temporarily enroll out-of-state providers, deliver care in alternative settings, such as, of course, telehealth, and it also allows states to pause fair hearing requests and appeal times. And these waivers are effective from March 1st and will end upon the termination of the public health emergency. And as Lindsay said, another disclaimer coming your way. So this list is not an extensive list of every provision under the waivers, and each state may have different provisions approved, as well as different ways of billing for their telehealth. So as usual, we want to encourage you to research specific Medicaid guidelines on a state-by-state basis. All right, jumping in here to our private payers. So just like Medicaid and Medicare, under that Families First Act, all comprehensive private health insurance plans are required to cover FDA-approved testing needed to detect or diagnose coronavirus and the administration of that testing. Plans are also required to cover any services or items provided during a medical visit that results in a coronavirus testing or screening. And these services or items can be provided during an in-person visit or via telehealth. All services must be covered without cost sharing, meaning patients have no out-of-pocket costs or barriers such as prior authorizations or other medical management requirements. So many plans are going beyond this requirement and starting to cover additional telehealth services beyond even just COVID services, at least temporarily. So United Healthcare, Cigna, Aetna, Blue Cross Blue Shield, and Humana have all released statements on their updated telehealth reimbursement changes. And of course, if these are some of your payers, we highly recommend that you research each plan and state individually. There's a really big range of different coding and billing requirements. Some require different modifiers in order to receive the correct reimbursement from each of your plans. And just one big slide going over our disclaimer again. You can read it here on your screen. And while we do keep putting these up, it's certainly not because we don't want to help you. So with the assistance of MGMA, we also have a list of questions up here that you want to consider asking your payers when it comes to figuring out exactly what your practice is going to need to document to make sure you're successfully reimbursed. So things like what place of service code should be used, which modifiers are necessary, and then a big one to point out here, so does your payer require audio and video to bill for telehealth, or can just audio be used? We want to caution you, the vast majority of payers are going to require both, specifically Medicare, as we already talked about, but there are going to be a couple that may allow you to bill just audio, so you will want to check into that. And again, we are sending these slides out hopefully by tomorrow, so you will have this entire list for reference as well. Okay, so moving into a pretty significant announcement from the DEA. And the declaration of this national emergency has enacted one of the telehealth exceptions to what's called the Ryan-Haidt Act, which was an act created initially to regulate online internet prescriptions. So beginning on March 16th and throughout the rest of the public health emergency, DEA registered practitioners may now issue prescriptions for all Schedule 2 through 5 controlled substances to patients for whom they have not conducted an in-person medical evaluation, provided that all of the following conditions are met. So one is that the prescription is issued for a legitimate medical purpose by a practitioner acting in the usual course of his or her professional practice. Two would be that the telemedicine communication is using audio, visual, real-time, two-way interactive communication system. And lastly is that the practitioner is acting in accordance with both federal and state laws. And as long as the practitioner satisfies these requirements, they can issue the prescription either electronically for Schedules 2 through 5, they can call in an emergency Schedule 2 prescription to the pharmacy, or they can call in a Schedule 3 through 5 to the pharmacy as well. And now I'm going to go ahead and pass it back over to Lindsay, and she is going to cover the major changes surrounding non-essential procedures.
Perfect, thanks Carly. Again, this is pretty straightforward, and to be honest, chances are if you are impacted by this change of basically CMS has announced that any non-essential medical, surgical, and dental procedures should be delayed during this COVID-19 outbreak. It's likely you're already aware of this because you've likely had to stop your practice operations. I mean, truly the main goal here is just to conserve PPE and healthcare workers and the spread of this as well. Important thing I want to point out here is as of Wednesday, 27 states had released official statements in regards to this, and we're actually providing that link here, and it's tracking all state announcements related to this elective surgery and procedure recommendation. And I encourage, if this does impact your practice, to use this link and see what your state's guidance currently states. Then we have the QPP MIPS changes. So basically, CMS did actually delay the deadline here for MIPS reporting for clinicians. The old deadline was March 31st, and the new deadline is actually April 30th. One thing I want to point out here is that within the announcement, you can see the 2020 data submission. It says CMS is evaluating options for providing relief around participation and data submission for 2020. I will preface this is a Lindsay prediction, this is not fact. But for right now, it could be possible that CMS mirrors what they did for the hospital side of things for providers. And on the hospital side of things, CMS did state they're not going to count any data from January 1st, 2020 to June 30th of 2020. So there is a chance for anyone who's worried, about your quality measures out there for a full year reporting that this could be reduced down to 6 months. It has not happened yet, but it did happen on the hospital side of things. Now, what's important to note with this deadline, basically, if any clinician has not submitted data by April 30th, the new deadline, they're actually going to automatically qualify for an extreme and uncontrollable circumstance policy, and they're going to receive a neutral payment adjustment from MIPS. Again, that's if no data is submitted. There has been some confusion based off the HQM homepage announcement that we've seen, that I've had clients ask, well, if we submit one category worth of data versus 2, would we still be able to take advantage of that extreme and uncontrollable circumstance? And the answer is no. You have to have submitted no data in order to get that neutral payment adjustment. If you still submit some data and you're under that 30-point threshold, you will incur a penalty. So based off this, there is a chance if you submit it through the QPP portal, you may want to delete your submission if you weren't on track to receive over 30 points. And if you did submit through the HQM and you have a similar concern, I would recommend you reach out to your HQM analyst. So in conclusion, I mean, we kind of have another disclaimer here, but this is how I see it. We're going to open up for questions here. I know we are a little short on time, but Carly and I both, we're not lawyers, we're not coding experts. We do try to act as industry experts here. Please don't throw virtual tomatoes at us when we likely have no choice but to say, please check your payer-specific requirements, your state-specific mandates, and your own internal compliance and billing departments in response to your questions. We really want to provide you with the most up-to-date information so you had what you needed to make decisions. and what you needed to know during this challenging time. What we do know is that telehealth will not be going away after this crisis. You know, you can see my reference to the toothpaste metaphor. Once it's out of the tube and being used, you can't put it back. So patients are going to experience this new type of visit, and they won't stop wanting it overnight. It's supported by that CARES Act moving forward with funding for the next 5 years. So just try and keep this in mind when you're trying to decipher what's best for your practice. I know it's a difficult time right now to think about a time even after COVID-19, but there will be one. So stay positive and truly let us know if we can help you in any way. So I will stop talking, Chelsea. I'll hand it over to you and see if we have any questions on the line as well.
Perfect. Thank you so much, Lindsay. And thank you, Lexi, for the information as well. I'm sorry, not Lexi. Thank you, Carly, for the information as well. If you have questions, you can type them in the questions area of the webinar control panel. At the moment, we don't have any. So if you have any, now's your time to ask them and we'd be happy to answer them. Otherwise, people might just be eager to get back to their day, and that's fine too if you drop off. And we'll wait on for a few minutes in case questions come. And again, I'll be sending out a copy of the slides and recording within the next day or so here. And we hope to see you at our other upcoming webinars as well in this series.
Yes, please. I hope I didn't scare you all with too many disclaimers to ask a question. Feel free to ask a question. Like I said, we're going to answer it the best we can. Truly, our goal today was just provide you with the information, with the links and the places you can go to get resources for your practice to stay up to date on this constant change.
And don't feel scared to ask a question. The most that we'll say is, I'm sorry, we can't answer that one entirely, but we can probably give you some resources of where to go to hopefully find a better answer for you as well.
And truly, when making this presentation, a lot of it was based off client questions that were coming in on a daily basis. So maybe that just means I was able to hopefully include all of our frequently asked questions and the answers that we had. Chelsea, I see one question may have come in regards to the payment adjustments for 2021. I believe you're referring to MIPS. That is a good question. So the question was in regards to basically payment adjustments coming in for the 2019 performance year based on the new QPP legislation. And it is true there, even if you are above the performance threshold, and you are on track to receive a positive incentive in 2021 based off your 2019 data, there's a chance this could impact you. If we see a lot of clients or practices or providers out there who choose not to submit any data now because there'll be a neutral payment adjustment, this could actually negatively impact your positive payment adjustment. It's a budget neutral program, so the penalties are what actually funds the incentive payment. So even if you did submit your data, you're done for 2019, it still may impact you from a sense if you are on track to receive a positive incentive payment in 2021, it may be a little lower than we actually expected it to be. So great question and great point.
Okay, well, it looks like that's it. Do you see any more on your end, Lindsay?
I do not, no.
Okay, well, thank you everybody for joining us, and thank you for doing what you guys do every day and being out there on the forefront and seeing patients and taking care of all of us. Thank you so much.
Perfect, thank you everyone.